Today we are going to talk to you about ALS or amyotrophic lateral sclerosis, which also means muscle atrophy due to lateral scarring. Today we are ALS, also known as Lou Gehrig's disease, is a motor neuron disease that affects overall muscle tone in the body. Patients lose voluntary muscle control due to the affected neurons. This is a fast progressive disease that can lead to death within 2 to 5 years of onset. Some famous people who has or has had ALS are Stephen Hawking, who was a genius and a physicist, Lou Gehrig, who was a professional baseball player, and Steve Gleason, who played in the NFL. ALS affects upper motor neurons and lower motor neurons in the cerebral cortex and the spinal cord. Proteins do not break down, which causes plaques in the brain, killing the motor neurons. This causes degeneration of our brain over time. Lateral scarring of the cortical-bulbar tract of the spinal cord causes peripheral nerve damage, resulting in muscle atrophy. The neurotransmitter glutamate is overproduced and microglial cells become present to clean up the area. The cause of ALS is still unknown for the most part. There are many risk factors for patients to get ALS. Some modifiable factors include being in the military, working with heavy metals and machinery, heavy metal workers such as welders due to the toxins in the metal, and toxins from smoking cigarettes. Some non-modifiable factors include it being an autosomal trait, which is hereditary or passed down from your family. It appears in the fifth decade of life and usually occurs in white males. ALS does not present with any sensation problems because this disease generally affects the central nervous system rather than the peripheral nervous system.
Now, for clinical presentation, cognitive impairments are noted in 50% of individuals with ALS. If there is frontal lobe involvement, executive function deficits can be found in visual attention, working memory, cognitive flexibility, problem solving, as well as visual perceptual skills. Now, the medulla, aka bulbar, can also be affected. Now, bulbar onset is more predictive of cognitive impairment than limb onset. If the medulla is involved, the person can present with the bulbar sign, which is weakness in muscles controlling chewing, swallowing, and articulation. They can also present with a pseudobulbar affect, which is uncontrollable emotional outbursts like laughing or crying. Basically, it's an emotional incontinence. There can also be upper motor neuron involvement. Now, symptoms of this is distinguished by spasticity and lack of dexterity. There can also be a decrease or complete loss of muscle strength along upper motor neuron patterns, which includes extensor muscles of the upper extremities and flexor muscles of the lower extremities. They can also present with a positive Babinski sign. Now, if there is lower motor neuron involvement, the first evidence of the disease is usually asymmetric weakness in the distal portions of one limb. Now, muscle weakness is also included in extensor muscles being weaker than flexor muscles, especially in the hands, and also cervical extensor muscle weakness, which would cause a head droop and pain with overstretched muscles. There can also be increased lumbar lordosis, in which the person will compensate to right their head and bring their eyes level. Facial nerves can also be involved, which would include their mouth, eyes, and tongue. They'll have drooling, dysarthria, which is slurred speech, claw hand, muscle cramps, as well as fasciculations. Now, one thing to note, throughout the course of the disease, eye movements and sensory, bowel, and bladder functions will be maintained.
Now to talk about the medical management of ALS. The diagnosis of this disease is predominantly made from clinical presentation and electromyogram test, also known as an EMG. A EMG is a diagnostic procedure that assesses the health of muscles and the motor neurons. For this diagnosis of ALS to be confirmed, it must have the presence of fibrillations, positive waveforms, fasciculations, and motor unit potential changes in multiple nerve distributions in at least 3 limbs and the paraspinal muscles. These changes occur without any change in sensory response. However, the time for the diagnosis differs. The first presenting symptoms involve upper limb onset. The time diagnosis is 15 months. Lower limb onset time diagnosis is 21 months, and bulbar involvement is 17 months. Now, often in the early cases and those that are progressing slowly, there may be minimal abnormality in the first EMG, and the changes that lead to the diagnosis may not appear until up to 6 to 12 months. In 1990, the World Federation of Neurology outlined the diagnosis of ALS into 4 separate categories. Suspected ALS deals with lower motor neuron signs in 2 or more regions and upper motor neuron signs in more than one region. Possible ALS, upper motor neuron and lower motor neuron signs in 1 region, upper motor neuron and lower motor neuron signs in more than 2 regions. Probable ALS has upper motor neuron and lower motor neuron signs in 2 regions, and upper motor neuron and lower motor neuron in more than 2 regions. And definite ALS with upper motor neuron and lower motor neuron signs in 3 regions, and upper motor neuron and lower motor neuron signs in more than 3 regions. The pharmacological treatment for ALS involves a combination of medications that are used to target more than one pathogenic pathway, which may slow disease progression in an additive or synergistic fashion. Medications such as riluzole, which is approved by the FDA and has a broad range of effects on the disease, is able to inhibit glutamate release, postsynaptic glutamate receptor activation, and voltage-sensitive sodium channel activation. In other words, the drug is neuroprotective and it slows the disease down by 15%. Another drug would be myotrophin, which is used to promote motor neuron survival and the regeneration of motor nerves. Now, there's no medication that can stop the disease, but much can be done through symptomatic therapy, which use anticholinergic drugs that control drooling, and another 2 drugs, bafloquine or diazepam, to control muscle spasticity. And this other drug, dextromethorphan, is a long-term use drug that suppresses coughing and is very effective in controlling tearfulness that results from the pseudobulbar involvement.
I'm going to be talking about the PT management of ALS. Now, to begin, we all know that this disease is not curable. The main goal for the physical therapist is to keep this patient independent and active for as long as possible. Now, before we get into exercise interventions and treatments and education for the family and the patient, I want to talk about 2 items I have here. The first item is the McGill's Quality of Life Questionnaire. Now, it's a 59-item tool. It's great for the assessment of the quality of life of the individual battling ALS. It talks about their spiritual, it's a bunch of questions, and it really gives you a rundown on how their life is dealing with ALS. The second is the ALS Functional Scale Rating. This mostly just follows the progression of the disease. It's more of a progress. It takes about 6 months to see any changes or detect any changes in their lifestyle, and it's really important to see how these patients really battle with this disease. As mentioned before, muscle strength declines with the progression of this disease, so it's very important to maintain a good general physical activity and prevent any stiffness or contractures and just a good well-being before this disease really takes over. This is really important usually in the first year that these patients are dealing with this disease, and it keeps them more active and independent and prolongs their independence for them.
Now, as Stevie mentioned before, spasticity is a common sign with this disease. A consistent slow stretch decreases the tone of the muscle and will help decrease spasticity and help prolong this prognosis for this patient. Two very important topics I want to talk about are gait and respiratory. I'm going to start with gait. Now, with gait, you know the hamstrings and the dorsiflexors start to weaken, which really can affect their gait. The PTA or PT needs to assess the gait because of this weakness of the lower extremities. Contractures are very common and need to be routinely stretched. And as we know, with the weakness of the lower extremities, falls are very common, so we need to assess fall risk for these patients while performing interventions. Next one is respiratory. Now, many of the respiratory muscles start to weaken. So as soon as this patient is diagnosed and as soon as they start treatment with you, prevention should be emphasized. Like I said, changes in the respiratory system occur with these ALS patients. An intervention, a PTA might even teach a patient with ALS to start using their abdominal muscles because their diaphragm muscles are starting to weaken, and you need to teach the patient a different way to breathe so they can prolong their breathing. Now to continue with the PT management, braces and assistive devices are used with these patients. Now, as we all know, again, this disease is not curable. These devices and braces will not fix them, but it will help them maintain mobility and freedom and independence for as long as possible. The lower extremity braces more so extend the time for an upright walking, extend more time being independent with ambulatory, and for these patients to just maintain independence for as long as possible. The upper extremity braces more so maintain the head and trunk control. It gives them an upright posture because as their muscles start to weaken, they might start to lean forward or not even be able to pull themselves back up. So it's very important with these braces to help them maintain more of a control of their trunk and head while this disease progresses. During the late stages of this disease, a lot of patient education and family education is very important as this patient starts to be very dependent on others. What you want to instruct the family is maybe adjusting their home environment. You want to eliminate stairs. You want to eliminate any clutter and make very clear pathways for these patients. Rails are very important if they are still ambulatory. It can help them be more independent in the house and help them maintain their independence for as long as possible. Now, when this patient is bedridden and they are dependent on you, proper bed mobility and transfers are very important in teaching with these patients' families. You want to know when to turn them, how to turn them, and the proper ways to turn these patients and move these patients without them progressing to any pressure ulcers or any sores that can cause real harm to these patients. Now, more so with talking with the patient. Now, boredom and frustration is very common with these patients. They're sitting there, they don't have much interaction anymore with more of the social life, so you want to instruct the family to have a lot of social gatherings and bring people to this patient to make them feel included and worth it. Now, with a lot of these patients, the topic suicide comes up. Now, you want to have a long conversation with this patient if suicide is a topic on their mind. They might ask you to assist them in suicide or to just let them do it. You want to explain to the patient the proper ways of doing things and to show them that there's a lot to life. Now, as this patient really starts to deteriorate, you want to have an end of life conversation with the families. They're going to have a lot of questions for you, and you need to really play a role in their decisions to do with with this patient, and be very respectful and courteous of their decisions, because it is their decision. Okay, now I want to talk about the exercise and rehab programs with these patients. Now, I found a really good chart in our pathology book that I kind of put on and kind of summarized in this PowerPoint. It really breaks down the stages and the phases that these patient goes through, and it shows their patient characteristics and the type of treatments you would use for this patient at that time of the stage. Now, as you can see, during the phase 1 and stage 1, it's the beginning of the disease. Patient's gonna show a mild weakness. They're still gonna be ambulatory and pretty much independent with most ADLs. What you want to do as a PT is you want to continue normal activities. Range of motion exercises are very important. Stretching exercises are important to prevent them contractures. You don't want to do too much resistance as their muscles are starting to weaken, and you want to be careful with their fatigue levels. You don't want to over fatigue them and get them to a point of no return. And as I said, this disease is very hard on these patients, and psychological support may be necessary in speaking with them and talking with them as they go through the beginning part of this disease. Now, we're still in phase 1, but this is the second stage of this disease. Now, they're going to show a lot of moderate weakness. ADLs are going to start to become difficult, including with climbing stairs, getting dressed in the morning, even washing their hair as the upper extremities start to weaken. You still want to continue stretching. It's very important to prevent any contractures. You want to be very cautious with strengthening programs with this patient as their muscles are really weakened now, and you don't want to cause any fractures or cause any tears with this patient. So very, very, very light resistance programs may be needed, and to help them with more independent ambulatory and ankle foot orthosis may be necessary for this patient. Now, we're still in phase 1, but this is now stage 3. Now, this is pretty much the same characteristics as it was in stage 2. In this stage, you really just want to try to keep this patient as physically independent as possible as they are nearing a more dependent lifestyle in the next stages. So you want to really prolong their exercises and really try to make them as independent as possible until they are no longer able to do so. Next, we're in phase 2 and the stage 4. Now the characteristics are the same. It's maybe a little bit worsened than the last 2 stages, but for the most part they're the same. At this point, the therapist would have to do more of an active assistive passive range of motion exercises, as they will probably not be able to go through their full range by themselves. Since they can't do the full range, you really want to encourage more of an isometric contraction of these muscles, as to help keep the muscle active and help strengthen the muscle. Ambulatory is still in effect here. They are still able to walk, but maybe not as well. So maybe a motorized wheelchair may be necessary to help them with independence and moving around the house. It might be a little bit quicker for them and help them do things a little bit faster. You do want to be careful, because when people do see a wheelchair, they might start to decline in their mental health and just give up. You want to just show them that this will help them get around faster and be more independent by themselves. Now, we're still in phase 2, but now we're in stage 5. Now, this is when severe weakness in the lower extremities really start to show. There's more of a moderate to severe weakness in the upper extremities, as the lower extremities are going to be taking a hit a lot harder than the upper extremities. These patients are now wheelchair dependent and ADL dependent. So you want to try to continue the exercises with this patient, but during this time, family education is very important. As I mentioned before, you want to instruct them on proper transfers, how to position, and how to do some modifications at home to help them progress in this disease. Phase 3, stage 6 is the last stage. This patient is completely dependent on any ADLs, and they are pretty much bedridden. During this stage, like I said, family education and is very, very important. You don't want this patient to contract any pressure ulcers or infections from them pressure ulcers. This patient probably will have swallowing difficulties and a very soft diet, and feeding tube is very important with these patients. As I said, this patient is very dependent at this stage, so you want to just try to prolong their life as much as possible, even if the end's near. Alright, now I'm going to talk about some precautions and contraindications to PT interventions. Now to begin, post-exercise fatigue. That is usually common when that patient is overworking themselves or the therapist is overworking them. You want to be very careful with fatigue with these patients. You don't want to have them tired. You want to try to maintain their independence and an active lifestyle for as long as they can. You don't want them laying around and their muscles deteriorating even faster, because we know that exercise is very important with these patients, but you have to be very cautious when doing so. Falls are very important with these patients. They're at a high fall risk as their lower extremity muscles are starting to weaken and deteriorate. It's very important to use caution in the physical therapy setting and in the home setting, and that's when patient education is very important. In the physical therapy setting, you want to have rails and utilize a gait belt as needed with these patients to prevent any falls. At home, you want to instruct the patient's families to put in rails to take away any uneven terrains, which include rugs, a transfer from a hardwood floor to a rug. That uneven terrain can cause problems, so you want to instruct the patient's families on how to adjust their home environment. Vitamins are sometimes necessary with these patients who have dysphagia and have trouble swallowing, but you want to be very careful and limit the amount of vitamins you give, which can cause very harm to their body. Bed mobility is very important with these patients. Patient education and family education is very important. Patient education is usually early, if they are able to move, to give them proper instructions on when to move and how to properly transfer themselves. When they become dependent and bedridden, this is when you bring the family into play and you want to instruct them on proper transfers and proper movement to avoid any pressure ulcers. These pressure ulcers can cause infection to the body, and you want to be very careful. Heavy resistance exercises are contraindicated. You don't want to overwork this patient. As I spoke before about the post-exercise fatigue, you don't want to overwork or even accelerate their deterioration and weakness of the muscles. You want to be very careful with these patients when doing exercises and prescribing proper exercises. Eating and drinking is very important because, as I said, this patient will just start to appear to have dysphagia, which is problems, difficulty swallowing. Now you don't want them choking on their food, and the choking on their food can cause the food to go into the lungs and even cause a very bad respiratory problem for these patients, and that might even accelerate their respiratory problems that they're going to have. Most places don't use oxygen with these patients as it can cause harm. You want to be very careful with oxygen. The only time you should really use it if it's medically necessary for maybe a different diagnosis. And respiratory tests like FVCs and PVTs are usually used with these patients. The big thing with these patients is their exercise programs to really make sure you don't cause any fatigue and the acceleration of deterioration of these muscles and weakness of these muscles.
So as there is no cure for ALS, the prognosis is bleak. The patient will not survive the disease, but as Kyle mentioned, there are some medical interventions that can help slow the onset of the symptoms. Overall, it takes generally 11 to 12 months from the onset of the first symptoms until the ALS diagnosis is made. And then on average, the patient lives anywhere from 2 to 5 years. I looked at a couple of studies, and one examined different factors that can affect the lifespan of the patient once the diagnosis is made. And the most important factor is the age of the patient at the time of the diagnosis. The older the patient is when the diagnosis is made, generally the less time they have to live. In the first study, out of the 728 patients that were examined, they were evenly distributed into age brackets of less than 50, 50 to 59, 60 to 69, and then 70 and above. And they're also split evenly between male and female. And then upon receiving the diagnosis, the patients below age 50 live for an average of 27 months. The patients 50 to 59 live for an average of 17 months. The patients 60 to 69 live for an average of 13 months, and then patients over 70 live for an average of 8 months. Then they also looked at the length of time between the patient's first symptoms and their first visit to a clinician, and they found that patients whose clinical visit was more than 12 months after the symptom onset lived for an average of about 5 months longer than those whose first visit was less than 12 months after the symptom onset. And they attributed that to being an indicator of the severity and aggressiveness of their symptoms. So they figured the more aggressive their symptoms, the sooner they'll be going to a clinician, and the more aggressive their symptoms, the worse their case is going to be. And here I just have a couple of charts from the studies that I went over. On the left is the study of the 728 patients, and then they're categorized by their different demographic informations. Their first is the sex, and then the age, then if the symptom onset is bulbar or spinal, and then the length of time from the symptom onset to the first clinical visit, and then the BMI of the patient. So the first column is the number of patients that are in each category, and the second is percentage of the total patients that make up the category. Then the third column is the average length of time in months that the patient in each category survived from the point of their initial clinical visit. The study on the right also measured the survival time based on categories of patients. They studied 575 patients, and it echoed the results of the first study, that the younger the patient was, the longer they survived. And this particular chart on the right shows the survival rate of patients once they were put on their non-invasive ventilators, and it's categorized by bulbar onset versus the limb or spinal onset. And both studies, they agree that the survival rate is much shorter for patients with the bulbar onset.